should be down at the bottom. There should be a little caret.
Good evening and welcome to the Cancer Education Series. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer. Tonight's Cancer Education Series is brought to you by MercyOne and Above and Beyond Cancer through a grant that we've received from the Iowa Cancer Consortium. It's my weekly pleasure to introduce the founder of Above and Beyond Cancer, Dr. Richard Deming, who will introduce our speaker tonight. Dr. Deming?
Great, thanks, Chris. And thanks everyone for joining us. It's my pleasure tonight to actually have a conversation tonight with a good friend, colleague, and teammate. Tami Singleton is a palliative care nurse who's been with Mercy for many years, and we've had the real pleasure of being teammates to take care of many, many patients. So we're going to have a conversation tonight about the role of palliative care in caring for patients with cancer. Hi, Tami.
Hi, Dr. Deming. Thank you. Thank you.
You're welcome. Tami, maybe I'll let you just introduce what is palliative care? How is it different from hospice care? And give us a little bit of background about palliative care, and then we can have a conversation about the role it plays in all the patients that you and I have the opportunity to work together with.
Okay. So I started out, and I'm sure some people are kind of looking at and wondering exactly why the name of this was Be the Butterfly or Become the Butterfly. And the reason for that is because I kind of see palliative care that way and hospice. You know, butterflies have kind of fascinated scientists for years, and ever since I've been a little girl, I've loved them with all their bright colors. But the reason they fascinate scientists is because the butterfly, it actually represents the final stage in a very fascinating life. And I kind of look at our patients who sometimes are diagnosed with those incurable cancers kind of in the same way. You know, they start out at the caterpillar with all those legs and all those people to support them, and they're running to this test and that test and getting chemo and getting radiation, and just all those legs are go, go, going with the whole thing to kind of get a handle on this disease. And as they get stronger, they kind of develop their own little cocoon and their own little world of people and around them. And that's kind of what palliative care does, is kind of wrap you in a cocoon of support. And while you're in there, just like the chrysalis is what it's called for a butterfly, your body kind of starts changing, things start changing about you. And eventually you become the butterfly. Most butterflies actually only live 7 to 10 days, although some, I guess, can live up to 6 months. But the butterfly during that final time of its life is this beautiful thing that gets to travel and see beautiful things and have joy and enjoy life. And I kind of see our patients in the same way. You know, palliative care and hospice care are both geared around that idea of wrapping you in that cocoon of support and love and helping to improve your quality of life, make it the very best it can be. When palliative care first started, it truly was more geared towards hospice and very end of life. But in the last 10 or 15 years, there's been a real push to kind of move us upstream, to kind of do that onboarding early. So hospice, every bit of hospice is palliative care, but not all palliative care is hospice. So hospice is for someone who has a life expectancy of 6 months or less if the disease progresses at its normal rate, although we all know that there's no such thing as normal, everybody's different. But as the doctors use their tools to prognosticate, it's at 6 months or less. They are no longer receiving anti-cancer treatment or aggressive medical treatments, either because they've chose not to, or they can no longer tolerate the treatment, or maybe right from the get-go they've decided that they don't want to go ahead with treatment. Where palliative care can be given at any age, any stage of an illness, even some curative diseases. But palliative care is really around that time while someone is getting that treatment, they've been newly diagnosed, or they're starting to see some of those changes, and we may be moving towards the end of life down the road, and you're needing support and guidance and that extra added care. It certainly doesn't take the place of your physicians. It's just an added service to provide comfort, with a big focus on symptom management, whether that's physical symptoms or emotional or spiritual. There, that it encases the whole patient and family, and whatever symptom or whatever thing in your life is going on that's affecting that ability to find joy and have a quality of life. Those are the things palliative care wants to focus on. I think you might be muted, Dr. Deming.
Thank you for setting up that distinction. And so as a cancer doctor, I think the hospice care is easier to understand, and you define that quite well. Hospice benefits, often insurance programs have hospice benefits, and enrolling patients in hospice care not only provides sort of a greater number of services we can provide for the patient at home, but it often ends up being economically advantageous for patients and families. But we would never enroll a patient in hospice unless their prognosis based on average survival was 6 months or less. And also when we enroll someone in hospice, it's with the understanding that we're no longer doing active anti-cancer treatment, not that they can't be getting care. Palliative care, as you did point out, is for any patient at any stage of the disease, and it doesn't even imply that you have an incurable cancer. You've defined it sort of from your perspective as someone who provides palliative care. As a doctor, let me kind of explain, when would I bring palliative care onto the team? Symptom management is one thing. So it could be a patient that's going through treatment that either has a lot of symptoms, pain, nausea, diarrhea, either from the cancer itself, or they're having a lot of symptoms from the cancer treatment. And having palliative care on board gives another care provider. So as I always say, when I bring Tami into the room and say, let me introduce you to Tami, Tami's going to be joining the team. Tami is a palliative care nurse. Her role isn't treating your cancer. Her role is anything else we can do that might improve your quality of life. So Tami isn't putting her heads together with us deciding which chemotherapy, which radiation, how to do the anti-cancer treatment. Tami is focused on the patient and their family. What can we do in addition to the cancer treatment that can provide relief of symptoms? Now, I will admit that every cancer doctor does palliative care. Every cancer doctor tends to not just the cancer, but the symptoms and pain and all of the other symptoms. But to have a care provider whose whole focus is not on the cancer, but on the patient is really beneficial. The other thing I would say is what a palliative care specialist can do is, as they get to know the patient, they are often very good at helping patients sort out goals and expectations. So extremely important at any point in time, but especially when you're taking care of patients who have cancer, that even if the anti-cancer treatment works, the patient is not going to be cured of their cancer. And there does come a time, and it's different for every patient, when do we transition from more anti-cancer treatment that's not curative to a different focus with the goal and expectation of quality of life. And there does come a time in every cancer patient's journey, and we're talking in journeys that might last 15, 20 years, when going to fourth and fifth and sixth line treatment that's not curative may actually make the situation worse, reduce life expectancy, and reduce quality of life. So part of having palliative care come on early is getting to know patients, understanding their desires, their philosophy, and talking about goals and expectations. Do you want to say more about that, goals and expectations?
Yeah, so we do a lot of family conferences because oftentimes the goal of the patient may not be the same goal as the family or even the physician, or it may be that it's just a real complex situation. It's a situation where that person is making those choices that they're making. Maybe they don't have all of the information. You know, some of our older patients, a lot of times when we ask them, tell me what you understand about why you're getting chemotherapy or why we're doing the radiation, and the comment often comes back, well, because the doctor told me to. Now the doctor's told him why, and he's taken that time to explain all of that, but sometimes it takes hearing that over and over again and really breaking things down to their level, finding out what their goal of cares are. That's the most important part. And then really looking at, okay, you're telling me this is and then if it doesn't, we need to find out why. Is it misunderstanding? Is it a family dynamic issue? Is it fear, you know, of having some symptoms? Are there spiritual concerns? Do they feel that choosing, say, maybe not to have a feeding tube is against their religious directives or their religious beliefs? What's really behind their decisions, and what is that what's leading their goal of care? What really is at the heart of the thing? It's kind of peeling back all those layers of the onion to get to it. And Dr. Deming is absolutely right. Most all physicians do generalist palliative care. There's absolutely no question about that. And as Dr. Deming and I have talked many times, there are some physicians who are very comfortable having these discussions and do a wonderful job. And there are others who would love to be able to do it, but don't have the time. We're a palliative care team. You know, we set about an hour, hour and a half aside for each patient visit. The docs just can't do that when they have other patients waiting to come in. And so you really get down to the gut of that person to know. And sometimes patients don't want to tell the doctor something because they've formed such a bond going through all the cancer treatment. They don't want to disappoint the physician if they decide that they want to stop. And I know it sounds silly, but we hear it a lot, don't we, Dr. Deming? I don't want to let my doctor down. Yeah.
Yeah, that's a very good point. And there are patients who will go from treatment to treatment to treatment, knowing that it's not a cure and knowing that it's not likely to be a benefit, but they don't want to let their doctor down by saying, you know what, I think we'll go without the treatment. Tami, I think we should share with our audience kind of one of the seminal studies that showed the value of palliative care. So it was published about 10 years ago in the New England Journal, and the patient population that was being studied were patients with stage 4 lung cancer, so incurable, treatable, but not curable lung cancer. And the group was randomly divided into two groups. The first group got all of the chemotherapy, radiation therapy, any management that they felt was appropriate. The second group got chemotherapy, radiation therapy, any management the doctor thought was appropriate, plus a palliative care expert was brought onto the team from day one. So the study lasted about 4 years, and as expected, every patient in the study died because all of the patients had incurable cancer. At the end, evaluating length of life, quality of life, cost of care, To no one's surprise, patients who had palliative care team member on the team from day one had improvement in quality of life in every measure in terms of appetite, nutrition, pain control, lack of anxiety, all statistically significantly improvement if palliative care was on board from the beginning. To most people's surprise, not only was the quality of life improved, but the quantity of life was statistically significantly longer in patients who had palliative care rather than those patients who didn't have palliative care as part of the treatment. And finally, to everyone's surprise, the overall cost of care was significantly less if palliative care, an additional service, was brought onto the team. And when the data was analyzed, we found that it was mostly related to the fact that the patients who had palliative care on board were less likely to go on to third and fourth and fifth line treatment that had very little likelihood of benefit and lots of likelihood of causing symptoms and side effects, and was very costly. So that decision was the patient's decision not to take third, fourth, fifth line treatment, not the palliative care, not the doctors, but by having palliative care on board and having conversations about goals and expectations, you don't automatically just go from one course of treatment to the next course of treatment to the next course of treatment. You pause, stop, and discuss, what is it I want to accomplish, and how much do I want to put up with more side effects with a treatment that isn't curative versus focus on quality of life. And Tami, you and I have seen that many, many times.
And I think the other interesting thing that came out of that study was the physicians involved also reported an overall increase in their satisfaction in working with those patients. And I think part of that is because they saw those patients truly enjoying life. They were more accepting of where they were in their journey. They were able to have easier conversations with their patients. And so the physicians also reported, an overall improvement in how they felt about that interaction with the patient. So that was really important too.
Yeah. One thing I want to focus on and get your opinion of this. So we're in the process at MercyOne Cancer Center developing a clinic living with cancer. So for patients who have treatable but not curable cancer. And one of the measures of success that whenever I'm taking care of patients with incurable cancer is looking for joy. And I often will say when I have a patient come back for follow-up, what brought you the most joy since I saw you 3 months ago? And encouraging people to look for joy. And then if there isn't, it's like, well, what does a joyful day look like to you? What would be a joyful day? And what can we do to make sure that you have more joy in your day and more joyful days? So that's always a parameter of measuring success in taking care of patients. And are there interventions that we can do? Are there, how do we manage the physical symptoms, the psychological symptoms, the stress, the financial stress, the philosophical and or spiritual turmoil? And we have lots and lots of teammates we can bring on to the team besides the doctor and the palliative care nurse. So maybe, Tami, invite you to talk about the joy as a measurement of success, and then maybe talk about all the other teammates that we might bring on to the team besides the doctor and the palliative care nurse.
Right, and I can tell you when you talk to those patients about what brings them joy, it's not usually anything around their medical care per se, unless they were having a lot of pain and they're out of pain. But their joy was the ability to go to their grandson's baseball game and sit comfortably and enjoy it. Or for some patients, it's just the fact that I didn't have to go in to get my blood drawn this week so that I could go next week to get my chemo to do that. I think that the joy we find in a lot of these patients is that time spent away from all the medical care, that time with family, that time with friends. It's a time that they get to really reflect on their life, validate that what the things are that really do bring them joy, and look at those things that might be standing in their way. As Dr. Deming said, collaboration is very important in palliative care and as part of the team. So there are a multitude of other services that we can use. In our palliative care, we have a chaplain. He is very involved because a lot of patients, as they're facing the unknown of the end of life, there's not any of us that have experienced it and been able to come back and say, this is what it's like. So there's that fear and a lot of questioning sometimes spiritually. So being able to help them get some of those answers, or just knowing that maybe there isn't an answer, but people are going to be there to walk beside you. We have medical social workers, both in the hospital, our social workers and care managers, and the outpatient setting to help. What can we do to relieve some of those financial burdens? What can we do to help prepare small children? A lot of times if we have a young person, what's going to bring them joy is that their children are taken care of and that they are happy and they're being able to engage with them. So how can we do some things and some legacy building with their children and their family members? We have nurse navigators who, even though the person isn't maybe doing aggressive anti-cancer treatment, whether they are or aren't, there's somebody there to help them and get through this whole crazy thing we call a medical system and navigate those systems from one place to another. We have a financial person that can sit down and help. Is it time to apply for Social Security disability? What are the other financial support systems out there that can help them? We have mental health professionals that can sit down and help them and, unpackage and bring out all those fears and that depression and that anxiety, and how can we help them to deal with those things so that that's not interfering with them finding joy in their life. And then we also have a lot of community supports with massage and acupuncture and yoga and working out at the Healthy Living Center. It just really goes, it's like dropping the pebble in the water when you get involved, and the ripples just go out on all the things that are there to help that person have the very best life he can be. And our job sometimes isn't to make that happen. Our job is to say, what does this person need and who do they need, to us to bring into this team to help them get to that point of theirs. It really does take a village sometimes, and there are times when there are 10 and 12 people involved. But if that's what it takes to make somebody have joy and feel comfortable with where they're at, then that's what we do. That's how we find it.
And one of the first steps is just good listening. There's a field of medicine we now call narrative medicine. So studies show that if you put a doctor and a patient in a room and the doctor asks the patient, how you doing, what's going on, within 20 seconds of the patient speaking, the patient gets interrupted. And the focus on many doctor-patient visits is just, what's the symptoms and what can we do to relieve it? Narrative medicine is more than just sitting back and listening. It's active listening and trying to get to know through a patient's storytelling, really, what are they all about? What makes them tick? Who's involved in their family? What's meaningful to them? And the way the practice of medicine is, there's not a lot of extra time built into doctors' schedules to be able to do that as effectively as necessary. So listening is the first part to providing comfort and care in general. And the more that we know about the patient, their family, their desires, their goals, the better we are able to serve them. So when I meet a patient for the first time, I don't have the 20 possible team members I could bring on. We listen intently and then determine who we bring on and at what time do we bring them on. I will also say that if you do take the time to sit with the patient and listen, and as Tami said, maybe the first time she meets with them, it's an hour and a half, the relationship gets established. Shorter visits in the future can be much, much more effective because you already have that whole background. You know, their marital relationship, their children relationship, the role spirituality or religion may play, their overall long-term goals, and it makes it much more effective. It also speaks to the importance, I think, of the relationships and the continuity of relationships. A lot of medicine nowadays, and there's some advantages to it, but we're going to shift work where it's like, okay, this day, this is who's going to see you. And they may have never seen you before, but it's their shift. There's some efficiency of that, but it's not patient-centric, and you lose something in just trying to pick up everything by reading the previous person's notes. Maybe talk more, Tami, about the importance of relationships as you get to know your patients and help be on their team for years.
Mm-hmm. Yeah, and I think that's very, very important. And as Dr. Deming says, there are times when we ask those questions, we get to know that person, and as that therapeutic relationship begins to develop and they trust you more, little caveats that they've thrown out during the discussion, and it may be something no more than, well, I see here you're married, yeah, and then they don't want to talk anymore and they go on. But as you build that relationship, you may find out that there's issues there within that marriage that are making that person not be able to find their joy. They're not being able to communicate, or that person doesn't want to talk about it. And as you build that trusting relationship, you would be amazed what patients tell us sometimes. And to me, that's such a privilege that they trust you enough to bare their soul and tell you some of the most intimate things about their lives and what they've been through in their lives that have them where they are today. And so being able to sometimes, just as Dr. Deming has said, and listen, there are times that there's not a need for us to say a word. It's just sitting there and listening, validating how they're feeling, but letting them know it's okay to share with us. We're not going to share things that they've told us in confidence unless it directly affects them in a negative way. I've had patients, and Dr. Deming and I have shared these patients where they've been comfortable enough with me to tell me that they're suicidal at the time. And so we have gone in and developed kind of this verbal contract that they won't harm themselves. We get them the help they need, and that they give me their word that they won't do anything with that. And if they start to feel that way, that they'll call me or Dr. Deming night or day. Those relationships don't just happen. You really have to be willing to give of yourself and let that patient know that you really are there for them. You're there and they can trust you, and that you trust them to be honest with you. So I think that relationship's very important.
And just to reiterate what we've already said, palliative care is not the same as hospice, and anyone along the way. In some patients, we bring palliative care on the team when there's a need, and then palliative care, if it's no longer needed, is not an extra appointment. We also feel that it's really important to integrate palliative care into the cancer center to make, patients have so many appointments, and if we can help bring the palliative care team into the cancer center to see the patient while they're already there, seeing the doctor for either a chemo visit or a radiation visit or a follow-up visit with the doctor, and the palliative care team provides the service along that line. Tami, there's a couple things that I'd like to have you talk about, and you have some tools that are documents that help individuals kind of put into word on paper kind of what their goals and expectations are, especially when it comes to end of life and advanced directives and 5 wishes. And And so I'd like you to just kind of touch upon that, because that's often can be a big, not necessarily a beginning, but as you get to know the patients, it gives them things to think about, because especially when we're talking about patients with incurable cancer. And again, sometimes they may live 10, 15 years, but there does come a time where you're not going to be better. And even those of us who've never been diagnosed with cancer have to understand. I mean, there's wills and there's trusts and all sorts of things that we start taking care of. Maybe talk about some of those things that you talk about with patients with incurable cancer that helps frame some of the decisions that need to be made.
Right. So completing someone's advance directive, that's just a very, very important part of what we do. And again, Dr. Deming's right. Not very often is that one of the first things we just jump into, although there are patients who bring it up and we get going. We use 2 documents here at Mercy. One is called the 5 Wishes. And the 5 Wishes is a document that the first wish is essentially telling who you would want to make decisions for you if you weren't able to speak for yourself. And before someone chooses that person, I always make sure they understand that sometimes the spouse may not agree, or the child they're naming, but that person has given their guarantee that whether they agree with the person's choices or not, they will act as their advocate and they will honor those, because we do run into situations where people just have different philosophies. And so it's very important that the person they choose to be their durable power of attorney for healthcare is willing to advocate and follow that person's wishes. So we name the person. The 5 Wishes talks about the medical care. So many people think that it's just, do I want CPR or do I not want CPR? Do I want to be on a ventilator or do I not? And it's not like it is on TV where you have a heart attack and you collapse. They do CPR for a minute or 2. By the first half hour of the show, they're awake, they're talking on their ventilator, and then by the end of the show, they're off the ventilator and back to work. It doesn't work that way. And we need to we spend a lot of time with people explaining what CPR really is, what their chances of survival are. We have documents that we can show them that really outline that. But it's not just that. It's things like blood transfusions and dialysis and IV antibiotics and all those other life prolonging things that may be appropriate now. But if the person's at the very end of life, what are their wishes as they progress through different illnesses? And the 5 Wishes document has several different scenarios, and the person can choose, well, yes, I would want that, or not at all, or yes, go ahead, but if the doctor determines that there is not a hope of recovery, then stop. And then there's always an area to be right out. And I help people, really express to me what their wish is. And then I usually write those words verbatim. So there's no question of what that person wants or doesn't want, and when they want care and when they do not. Sometimes people want care no matter what. That may not be what I would choose, or that I even think is in their best interest. But if that's what they want, our job isn't to go in there and take our agenda. It's to ask what they want and get it documented. Then there's talk in the 5 Wishes about how you want to be treated, how you want your pain to be controlled or not. And believe it or not, there are people, due to their religious beliefs or other things, that feel that suffering is necessary at end of life and do not want pain medications. So again, you're having those long conversations and really getting to the heart of what they're thinking and making their wishes known. And then the end of it does talk about funeral planning and cremation and body donation and making amends with people if they choose to, and what they want people to know. And one of the questions is, what do you want people to remember about you? So that page takes a long time. It's really thought-provoking, and it really helps that person kind of make a life review and really think about what he wants and how he wants to be remembered. And then there's another document that we're using even more frequently now called the Prepare document. And it's got all of the same information, but it's a little simpler to follow, a little clearer, but it does all of the same things and comes at the end of that with the same information as written down. And then the other form that we use a great deal is called the I-Post, and that's an out-of-hospital order. So in Iowa, if a person says that they choose not to be resuscitated, or they want limited interventions. If you were at home and that were your wishes, but you collapsed, and then the neighbor sees you and gets you into the house, but you're not breathing or your heart's not beating, they're going to call 911. In Iowa, that implies that everything is to be done. And unless there is a physician's order that they do not have to do those things based on the patient's decisions, by law, they have to go ahead. So we have an I-Post form for those patients that say, I don't want that. And it is signed by a physician. It addresses not only ventilation and CPR, but tube feedings. And then that is reviewed frequently. On the back, there's an area for physicians to review that, because as disease processes change, the person's decisions may change as well. Most of our patients choose for limited interventions, basically saying, yes, take me, I want IV fluids and I want antibiotics, and I might even use a non-invasive vent to help me breathe, but if my heart stops or I stop breathing, I do not want to be placed on a machine. So we will spend a lot of time going over those forms to make sure we really understand what that person wants. And then we go over it with the person they named as their advance directives to make sure there's no misunderstanding or no question on their understanding of what the patient wants, and that they're willing to adhere to those. So advance directives are, they're important for somebody at end of life, and we really talk a lot about that. But the truth is, every one of us should have that, because none of us know, do we, Dr. Deming? We might be out riding our bike and something happened. So
yes,
we
exactly.
have to have something so we all know, so we're not all standing around guessing. And the time to ask those patients those questions is not when they're frightened and at end of life, and if they're struggling with a symptom, to stand over and say, do you want us to help you? The most important thing,
or ask the family, and like
what would they want?
30 seconds to decide.
Exactly.
One of the things that you mentioned that I think is so important, and that definitely bringing it early, really bringing it early into life. We should ask ourselves at age 20, at age 30, at age 40, at age 50, how do I want to be remembered? Because eventually, am I living my life in accord with how I'd like to be remembered? And I think that one of the real advantages of bringing palliative care on is that philosophical approach to reflectively looking at your life. Am I living the autobiography that I would like somebody to read at the end of my life? And if I'm not living in accordance with how I'd like to be remembered, regardless of whether I have incurable cancer or not, maybe I'm not living my life in alignment with my overall goals and expectations. And so if you're at a point in time where maybe you have 1 year or 2 years or 5 years left, now's a good time to align how I live my life every day with how I want to be remembered.
And we do in palliative care, we do a lot of legacy work, really setting down and what is the legacy you want to live. And I know there are a lot of times when someone is at the end of life, we mention to them what a gift it is and what a legacy they're leaving for their children and their grandchildren, because of the grace and the courage they're facing end of life with. And a lot of that legacy work, just like Dr. Deming said, really helps people look at their day-to-day life And we've seen kind of some remarkable things come out of that and some changes in people. I think sometimes we put people in a box and we stereotype and we do things that, we shouldn't. But when you really sit down and get to know that person and find out who they are at a heart and help them to look at that and start building their legacy, it really truly is a gift, not only for them, but for us to see that transformation.
So change gears a little bit. Maybe one thing I want to ask you is, reflecting back on some patients, what are some crazy, totally out of the box things that you have done for the patients you're caring for as you're helping them find joy in their life? And please don't admit to anything illegal.
Oh, well, that takes out some of it. I think of a couple people. There was a gentleman that had a brain tumor. This gentleman in his earlier life had been a very prominent attorney in the Des Moines area. I first met him, actually. This just shows you how life connects things together. I first met him working when I was an emergency room nurse, and he was homeless then at the time, and he would come in periodically with wounds and different things, and he was very well read. He loved literature, and he could tell you about all the great authors and poets and recite poems. He was a very remarkable man. But then I kind of lost touch with him when I moved out of the emergency medicine field, and he ended up here in the hospital with a brain tumor, and he was blind. And he was still homeless and living by his choice. And he lived actually under the bridges behind the Des Moines police station. And I don't know for any of you that were around here at the time, but maybe you remember when at McDonald's, you could get 10 hamburgers and 10 small fries for $10 on Tuesdays. So the people in the camp, when I would go, would kind of scatter, but I always I was there to protect me, because there were other people that maybe thought in my bag I had meds and things. And I'll never forget when he was nearing end of life and he was in the hospital. I thought I was doing a wonderful thing, because we just didn't feel it was safe for him anymore to be out on the street. Again, putting my agenda on his, and feel, he'd want cleaned up and his haircut and all of that. He went to our hospice facility, and he did love his whirlpool bath, but he didn't want his haircut. But he would roll all of his things up in a ball on the bed. And I remember going in one day, because he spent most of his time until he was bedbound sitting out on the patio. And I remember straightening up his bed and putting a pretty quilt on it and do it. And he was so angry. So as he neared the end of his life, I took all of his blankets and I took those out on the patio outside. I had an air mattress from home, and I put that down, and I wadded all those dirty blankets up on that air mattress, helped him outside to lay down on that, and then I sat with him there until he passed that night, because that's what he wanted to do. And that was where he found joy, was being outside. It had nothing to do with a nice fireplace and clean sheets and all that. And it took me a little while to figure that out, but that was an experience I'll never forget. And then I think one of my other experiences that show you the importance of palliative care was a young woman who was in her 30s and had metastatic breast cancer and lots and lots of pain. Had a small son, 2 years old, and I was having a horrible time getting her pain in control. It didn't matter what I did, I wasn't getting there. And I remember her constantly telling me that it felt like the devil had a hold of one hand and God had the hold of the other. and she would scream, and we had to remove that little boy from the home for a while because it frightened him. So I had the chaplain come and say, there's something more here. It's not physical pain, there's more. And he came and talked to her and found out through talking with her that when she was, and she was a very strong Catholic, that when she was 16, she had had an abortion and nobody but her mother knew. And she was afraid that she was going to go to hell for that and that her family wouldn't forgive her. So she gave us permission to tell her husband, and came in, went and got the little boy, brought him in. There were lots of tears, lots of saying it didn't matter and they loved her. We were able to really lighten up on the pain meds so that she was awake. Within about 3 days she died, but they were all together in bed happy and she wasn't in pain. So I think those are some of them. I did help an 89-year-old woman understand that the marijuana plants that her grandson was growing for her were not to be shared with anyone. She was just as cute as could be, and she thought that grow room was the greatest thing, and maybe someday it would be legal. But that day I helped put black-up shades in the window so no one could see what was going on in the room. So it's kind of whatever it takes to make people happy.
Yeah. And I think of times of, patient that was nearly quadriplegic, and making sure that, that they had the devices they need, and that they were able to have some joyful experiences, whether it was, assembling a small group to celebrate a birthday, whether it's, sharing poetry, whether it's helping create some art experiences. It's helping find joy along the way. And it's so much more. Taking care of cancer patients is an endeavor of human beings taking care of human beings. It's not about how to kill cancer cells, it's how to take care of people. And patients that are going through the journey recognize that, realize that. And it doesn't surprise me anymore, but it still delightfully amazes me how a patient can come in and we just sit and talk for 15, 20 minutes and haven't changed the medicines, haven't really done anything. And the statement is, I just feel so much better after I've been with you. And the idea is, feeling better is part of the whole process. And that happens from these relationships that establish, and listening intently, and making sure that we're always focusing on quality of life and joy. And again, just to restate what we said at the beginning, palliative care is brought on board even when patients are going through chemotherapy and radiation therapy.
Totally.
So it is a both and. It's not that a patient has to choose whether to receive palliative care or anti-cancer treatment. You can get both. That's the great thing. Once we get to the point of palliative care, and for those who've been with us the whole time, we just find the distinction. Palliative care is really very much at the very end of life, where we stop doing anti-cancer treatment, just focus on comfort care. But palliative care, as we're defining it, taking care of patients with incurable cancer that may live 10, 15 years, oftentimes they're receiving active anti-cancer treatment while they get the benefit of the TLC and the surrounding of support that comes from palliative care.
Right. And what we're, for this particular group, we're really focusing on cancer, but palliative care is for trauma patients. It's for neurological patients, strokes, ALS, MS. Fortunately, with all the new changes in medicine, we don't see very many AIDS patients anymore, but it is for those patients. And it's just truly an opportunity to surround that person and make sure they have everything they need to have the best life they can have. And trust me, when we do get those patients that live 10 and 15 years, we love it. And there are some social workers will say that, and I'll be first to admit this is true, I don't know my boundaries. I've been to more birthday parties and Christmas parties and celebrations with patients and families that I've gotten to know through hospice, and I wouldn't change that for the world, because I just know that those relationships are going to make the end of a life, whenever it comes for that person, better. And absolutely has made me better along the way.
Yeah, that's a great point. Not only does the patient benefit from this philosophy of care, but we, the caregivers, we, the professional caregivers, also benefit from this philosophy of care.
Yeah.
So I think we're going to wrap it up here. Again, we've been talking about the value of palliative care in the cancer world, and the distinction between palliative care and hospice care. And I really love the philosophical perspective, the palliative care, but it also is about managing symptoms. So some of the things I've already told you, when I put Tami in the room, I say, now, Tami's not involved with figuring out how to treat your cancer cells. It's all about how to make you feel better. But I sometimes introduce her as the queen of poop.
Yeah,
because,
she does frequently. Because if you're constipated, I can fix you.
Yes, she can fix you. So some of the physical things that we deal with together are pain, but we also deal with sleep and with constipation. And I've often said that, boy, if everybody in the world could get a good night's sleep and a good poop in the morning, there would be world peace. So sometimes we're philosophically dealing with meaning of life, but other times it's about just a good night's sleep and a good poop.
Good poop, yeah. Yes, for Christmas this past year, Dr. Deming knows my daughter well, very honoring. Brittany happens to be in a wheelchair, so she struggles with constipation. So for Christmas this year, she gave herself a gift from me, and it was a red t-shirt with a stick figure doing this, and it says, "I pooped today," because that's usually how we start our conversations every evening is, "Did you poop today?" So, yep, I'll be the queen of poop. That's okay. People feel so much better afterwards.
Yeah. Well, thank you, Tami, for
Yeah,
being
thank
with us
you.
this evening. And even more importantly, thank you for all you do for all of our patients.
Yeah, my pleasure. And if anybody ever has questions or you need anything, just call. I'm more than willing to help any way I can.
Great. We're going to turn it back over to Chris, who's going to give us the wrap for the outgoing.
We did have one question about insurance coverage for palliative care. That may be a long answer to a short question.
It's really not. Right now, palliative care is not necessarily covered by insurance per se as palliative care, although Dr. Deming and a lot of us are working with insurance companies and legislators to try and get that. But we do work with some of the organizations to do home care. So if you meet the home care benefit, we add the palliative care link to that, so that they get some of the care they need from a home care nurse and then a hospice palliative care nurse. Someday it'll be covered. I know it will.
But the other thing I would say is that when we bring palliative care onto the team in the cancer center, so I have Tami come in, there's no charge for that. When Tami joins our cancer care team as a palliative care nurse, there's no charge to insurance, there's no charge to the patient. So that's not of concern. So I would encourage any cancer patient who is dealing with symptom management issues or sort of meaning of life issues to ask if the palliative care nurse could be part of the team.
Yeah, absolutely. We'd be happy to do that.
Well, Tami, thank you very much. This has been very
thank you.
informative. And this session has been recorded and will be part of our Above and Beyond Cancer YouTube channel. It will also be available through MercyOne's website if you type in Cancer Education Series. So these are all recorded in there from all the weeks that we've been doing this, about a year now. So
Great.
A very informative session again tonight. Tami, thank you very much. And we appreciate everybody tuning in and being here in person at the MercyOne Health and Fitness Center. Take care, everybody.
Thank you. Bye, Dr. Deming.